All right. Spinal cord injury. Causes, MVCs, falls, violence, sports, miscellaneous. Okay, etiology and pathology. So the initial injury, what happens? You have cord compression, which can cause bone displacement. It can cause an interruption of the blood supply. This will be the only one in pink, I believe. The rest of them are easier to see. It can be traction from pulling on the cord. Or penetration, where like penetrating trauma, where you either have a tearing or a transection of the cord itself. So these are all the different ways that initial injury can happen. Cord compression, bone displacement, interruption of blood supply, traction from pulling on the cord, and penetrating trauma such as tearing or transection. So this initial injury is divided into two things. You have the primary injury, which is that initial disruption. So what is the whole purpose of the spinal cord? It sends nerve messages, right? So for whatever reason, your cord's been compressed, it's been transected, you've had a bone kind of cut in there, you've had a loss of blood supply, something happened that no longer can send transmissions, right? Nerve impulses. So that's what happens initially. What can happen secondary is this ongoing progressive damage. They have lots of theories of what happens here. But this is the most important because we can't do anything about the initial injury, right? It happened. But we can do something about the secondary injury, or we can help prevent it. That's our goal as the nurse. So you can write this down. I wouldn't stress too much about it. There are several theories out there that because of ischemia or infarction or hypoxia or the hemorrhage, whatever reason, it causes ongoing damage to the spinal cord. That's why you've heard we give steroids to help decrease inflammatory process. But there's all these different theories that they have. I think your book goes way in depth into it. All you guys need to understand is that you have an injury and then your body reacts to that injury. And we want to kind of stop how your body's reacting so that there's no more additional injuries. So, again, this is what I've been saying this whole time. The initial care or management is initiated ASAP. We want to start treatment right away because we want to limit any further destruction. We typically will know the prognosis within 72 hours. So a lot of times your patients will come in and they've just been in that car accident and it's been 8 hours and the family's like, will they ever walk again? You know, they're not moving their toes right now. You don't know that yet. What you do in that first couple of days will make a big impact on the long-term care for this patient. I know this pink is hard. It came out weird here. It's not weird on when you guys record it, it should not come out as weird, but for whatever reason it's this. But this is the only slide that's like this.
Can you just read the last part? Because it's in the...
Extent of injury prognosis is most accurate 72 hours after the injury. All right, so we classify spinal cord injuries 3 ways. We classify it by the mechanism, by the level, and by the degree of injury. So the first way is the different mechanism. You can be flexed. So like when you get into that car accident and you go and you hyperflex your neck, and it kind of causes, again, bone, compression, anything that we talked about. You can hyperextend. So someone, what the example is, she tripped and kind of fell on a desk and hyperextended her neck. I believe this is in your book. I have no idea what page or number.
On page 1471.
Compression, we think of compression injuries like those who dive into a pool. The spinal cord just kind of collapses on itself. And the ones that are the most unstable is when they flex and rotate. So they flex and rotate.
You say those are the most severe?
They're the most unstable.
Most unstable.
Yeah, because they have more ligament and bone damage. And then they don't have a picture of it. It's the same kind of thing, like the flexion and rotation. You can have extension and rotation. And again, it's also a little bit more unstable because there's a higher extent of injury. Huh?
Is that what they do like in the movies when they're like
Oh, like, yeah. I guess, yeah.
this?
I mean, that would be a good example. So when you break someone's neck in a movie to kill them, thank you, Morgan, for that wonderful example. All right. So the level is whether it's skeletal versus neurological. So skeletal is basically just what vertebrae did they get injured. Neurologic is the lowest segment of the spinal cord with normal sensory and motor function. So just because you have a skeletal injury at T5, your neurological injury could be at T7. And there's a difference with that. So your neurologic is the lowest segment of spinal cord with normal sensory and motor function. And that should be on both sides of the body. If it's, let's say they have normal motor function from T6 and below, on both sides, that's the level. If at T8 they can move their right side but not their left, then that's not normal. That's not their neurological function. We're going to talk about the difference in just a second. So there's all the different ways of how they classify it. How they got hurt, so the mechanism, the level of the injury, and this is where you hear the terms like, you guys used to hear quadriplegic. We don't use that anymore because we like to confuse everyone. It's called tetraplegic, which is just more descriptive, that 4. So if you have a cervical injury, you're most likely going to be tetraplegic. Everything else is paraplegic. So if you have a thoracic, lumbar, or sacral injury, they consider that paraplegia. If it's cervical, you're going to be a tetraplegic. Someone have a question? Any kind of cervical injury, you typically are tetraplegic. So skeletal just tells you the vertebrae itself that got injured. Neurological tells you about at what point do you have normal sensory function on both sides. And just a little bit further, typically if you have some kind of cervical injury, you're considered a tetraplegic. If you have an injury anywhere else, it's a paraplegic. It,
Are they interchangeable or is it just like?
they're that's what they want. That's the term to use now is tetraplegic instead of quadriplegic. Yeah, but they're, I mean,
Right.
it's like when people say MI or heart attack, they're essentially the same thing. Then there's the degree of injury. It can be complete. So this means at T6, and I just keep saying T6, it could be anywhere. But at T6, everything below T6, there is a total loss of sensory and motor function. So everything below the level of injury, there's loss of function. It can be incomplete if there's a mixed loss of voluntary motor activity and sensation. So basically, incomplete, some of the tracks are intact. So what's the term we use when we say one side? Ipsilateral, right? So these are your patients that typically have like below T6 ipsilateral motor paralysis or ipsilateral sensory paralysis, right? Because they still have some tracks involved. Or they may not have feeling in their quadricep, but they can feel their heel when you touch them. They can't still move that necessarily, or maybe they can wiggle their toe, but can't move their knee. Can't pull up their knee. So some tracks are making it through, but not all of them. So it's incomplete. Does that make sense? So we're going to say their neurological function is at T6 because that's where they have full. But their incomplete injury starts at like T8 because they still have some sensation below that. Is everyone understanding the difference? And complete just means that typically the completes are like your transections that happen where they just, the spinal cord is completely kind of cut. You just lose all motor and sensory function below that level of injury. You good? All right. All right. So the clinical manifestations, they're all related to the level and degree of injury. All that stuff that we just talked about, obviously, the higher the level of injury, the worse the clinical manifestations. They correlate. So, and basically, if we have an incomplete injury, you're going to have more variable clinical manifestations, right? Because they're getting some messages through and some not. So, respiratory system. You're going to want to leave yourself some room, and I'll show you. Because we're going to come back to these slides to put your nursing care management on there. You'll see what I'm talking about. If the injury is greater than C4, there's a total loss of respiratory muscle function. These patients require mechanical ventilation. Huh? Oh, that's okay. That's going to be important to know. Why is that important for you to understand? Okay, so you're in the ER working and they bring you a patient. So this patient was just involved in MVC. Yeah, you're going to intubate, right? Or are you going to sit there and try to bag the patient or be like, how's your breathing? No, you're going to know that this patient has lost all respiratory muscle function. So we're going to go ahead and intubate and get them ventilated right away. With injuries below C4, so C5, C6, C7, T1, anything that's the lower part of the cervical tract or typically your higher thoracic, they're variable, right? Sometimes they can get some diaphragmatic breathing. They can't take those nice, big, deep breaths. So they do this little. Do you think that they're going to breathe very effectively? No. So these patients are at high risk for some respiratory insufficiency. So anywhere like I said, C5, C6, C7, the thoracic area, they're at risk for having respiratory insufficiency. Some of them do well with aggressive therapy and aggressive nursing management and don't need to be mechanically ventilated. But there are some that don't do well, or when they're sick, or when they can't move around a lot or something happens, that they're at high risk for respiratory insufficiency. So again, why is that important for you guys as the nurse to know? Huh? Yeah, because if they come into the hospital because they're sick and they're not moving around as much, and you notice that their respiratory rate is higher and that they're not breathing as fast, what are they at risk for? Pneumonia. They could decompensate, right? Develop a respiratory acidosis or alkalosis. So you're going to be looking for signs and symptoms for that. And then with all cervical and thoracic injuries, there's a paralysis of the abdominal and intercostal muscles. So they're not going to get, like we talked about, those big deep breaths. They really have to work at it. They don't have a great cough. This is what we kind of talked about. They can develop atelectasis or pneumonia, so they're at increased risk of infection. Oh, pulmonary edema too. Sorry. All right, so cardiovascular. So anything above T6. So if you have a cervical injury, T1, T2, 3, 4, 5, anything above T6, your SNS, your sympathetic nervous system, is not working great, has a decreased effect. What does your sympathetic nervous system do? Regulates what? Temperature. What else? We're talking about cardiovascular system. Heart rate. So if we can't regulate the heart rate, what's going to happen to it? Be low. What does the sympathetic nervous system do to your vessels? Does it constrict or dilate? What does it normally do? It constricts, right? So if your sympathetic nervous system isn't working, what's happening? Everything's dilating. What do you think is going to happen to your blood pressure? It's going to plummet, right? So you have this peripheral vasodilation that's going to cause hypotension. In addition, if you've had this, so you have a vessel, right? And it's full of fluid. And now you have the same vessel that's like this with the same amount of fluid. What's going to happen to your fluid status technically? It's going to go down, right? It's a relative hypovolemia. So you don't really lose any fluid, but because all of those vessels are now dilated, not only is your blood pressure going to drop, that's partly because of the hypovolemia that's happening, that relative hypovolemia, secondary to those dilated veins. All right, so urinary system. What's one of the biggest things we have with spine injuries? Retention, right? So we get urinary retention, especially when we have lower level injuries like the thoracic injuries. And we're going to talk about spinal shock in a minute. And with spinal shock injuries, we typically will see urinary retention. So what does urinary retention do to the bladder? Distend it, right? You get a nice, big, full bladder. What happens to all that urine that's sitting in that bladder? Where's it going to go? Back up to the kidneys. What's going to happen to your kidneys? They're going to keep working? Nope, they're going to fail. What else is going to happen? If it's not backing up to the kidneys, what could happen to your bladder? It could rupture. You think that's pretty good? No. In addition, urinary retention, because it's backing up to the kidneys, it may cause kidney failure, can also cause UTIs. These are in, you'll see in a minute when we talk about nursing care management. We're going to use these same slides for nursing care management, so do leave yourself some space. That's why there's space on there. I always do my clinical manifestations in green. Treatment's going to be in blue. Neurogenic bladder. You can write all of this if you really feel the need, but basically it's all that urgency, frequency, incontinence. They want to void but can't void. They have high bladder pressure, and again, it just refluxes to the kidney. It causes the renal failure, it causes UTI. So depending on the level of injury and depending whether they're in spinal shock, they can just get some urinary retention or they can have a true neurogenic bladder. GI. If it's higher than T5, so anything cervical, T1, T2, 3, 4, what's going to happen to your system? Is it going to be working the same? No, motility is going to go down. Hypomotility. So if things aren't moving the way they should, what can develop? Constipation. They can develop an ileus, right? Things aren't moving. And gastric distension. Do you have your book open, Morgan?
I sure do.
Do you think these patients are stressed out? What does the stomach produce? Acid. So what's going to happen to their acid levels? Increase. So they're at risk for stress ulcers? If they had this injury because they had injury to the back or a car accident or anything that was hit to the stomach that caused the injury, they could be at risk for intra-abdominal bleeding. Plus the fact that if they develop a paralytic ileus and we keep feeding them because we didn't think about that, we could rupture their stomach or their intestines. So they're at high risk for intra-abdominal bleeding. And then just like with neurogenic bladder, they can develop neurogenic bowel, which is the constipation everybody thought about right off the bat. So yes, they're at really high risk for constipation. Skin. Obviously, they're not moving around like we do. They're at risk for skin breakdown. And I hate this word. Poikilothermism. I can't even promise you I'm saying that 100% right. So it's Poikilothermism. Poikilothermism. And does anybody know what that means? So again, we have this interruption of the sympathetic nervous system, right? Can the sympathetic nervous system get from point A to point B? No, there's some disruption there. So it's basically this inability to sweat or shiver below the level of injury. So if your injury is at C4, anything below C4, they can't sweat or shiver. If it's at T1, it would be anything from here, or no, I guess T1's up here, duh. T1, anything from here down. It's wherever the injury is, below the level of injury, they can't sweat or shiver. So what happens then? They can't regulate their body temperature. And they have fluctuating body temperatures, right? So they're like like an alligator. They're going to adapt to their environment. So if you have covered them with 400 blankets, they're going to get real hot, and they're not going to know that they're hot because their body's not going to sweat. They're not, or if they're cold, if you forgot to put blankets on them, they're not going to shiver. So they're not going to have any signs or symptoms that they're cold, and they can't feel that below the level of injury. So you have these two different body temperatures, and it's fluctuating. And the degree of this depends on the level of injury. So obviously, the higher the injury, the more common this is. Because if you have a C4 injury and you can't control your temperature from the neck down, that's more significant than if you have a lumbar injury and you can't control it from, the pelvis down. So again, it's all this sympathetic nervous system that can't regulate itself. It can't control the heart rate like it should. It can't control the body temperature like it should. Yeah.
So if they have an injury, say, in lower T8 or T9, where they can't feel the temperature regulation below that level, if you take the temperature, will it be accurate to what how are you going to know whether below?
If you took a temperature, it would be accurate. They're just not able to regulate it down below. So and that's why it says it's really the degree of that is going to be way more common with cervical injuries than it is lower injuries. We're not going to see as much fluctuation or as much problems with a lower level injury. But when you take a temperature, it's going to be accurate. But they're not going to be able to tell you my legs feel cold or I feel hot. Can you take that blanket off me? And they're not going to, it's not like when you see someone sweating or you see them shivering. You don't see that with them. They have a hard time. So you have this fluctuation in the body temperature real fast because they can't regulate it. Because that sympathetic nervous system can't kick in to say, oh, they're shivering, they're cold, let me turn up their body temperature. Or they're sweating, let me cool them down. Or they're hot, let me sweat to cool them down. Does that make sense? Did I answer your question? Okay. All right, metabolic needs. Be careful with suctioning these patients. Remember, we're going to talk about it more in test 3 when we do ABGs more in depth. But anything that we take from the top is metabolic alkalosis, right? Anything from the bottom is metabolic. Yep. So they're going to get altered electrolytes, especially sodium and potassium. They have a weight loss greater than 10%. Or they're at risk for weight losses greater than 10%. And they kind of will lose this sense to eat, especially those with higher injuries. Think about it. If you're thinking about who's at highest risk, males. Okay? So imagine our males in the classroom, or think of your nephew or your son or anybody like that's at that age. They're 18 years old, they're in their prime, we're goofing around, someone dared them to jump off the roof into the pool, and they got a spinal cord injury, and now all of a sudden they can no longer walk, they can take care of themselves, they're not hanging out with their buddies, they're completely dependent on care, they have very little control over their life. What is one thing that they can control? Eating. And they will bite down on that and take, well, that was not meant to be a pun, but they will take control over that and so refuse to eat sometimes. Their motivation is not there, and there's little that they can control, and this is something they can, so they often develop anorexia. Peripheral vascular, they're at high risk for DVTs, right? Hemostasis, blood's not moving. Sorry, my children have an emergency. I apologize. Or pulmonary embolism. And this is the leading cause of death for them. And again, it's just because there's this loss of their whole system. Blood is kind of pooling. They're not moving around as much. Musculoskeletal, they have big instability, right? And what's our goal? What's our goal? Prevent, I was going to say it's right up there. To prevent further injury, right? They get muscle spasms. And they get contractures. All because they're not using their muscles the way they normally do. Sexuality is obviously impacted. Males, they can develop erectile dysfunction. Again, the SNS is involved. It doesn't work the way it should. Sometimes they get priapism. Females. They're laughing at me because I get embarrassed. Lubrication becomes an issue. They remain fertile. So they think, oh, I had a spinal cord injury. I can't get pregnant. Yes, they can. So they tend not to maybe use protection because they think that because it won't work the same. Their ovaries are working. They can still become pregnant. So they still need protection. Psychosocial, obviously there's a big sense of loss. And that's not just for the patient, but also for the family. Like we talked about, what if this was the dad and he was the breadwinner and now he's not there to do that anymore? Mom has to go back to work. Kids have to change how they're taken care of. Loss of control. Wide fluctuation of emotions. And there's a big difference between acceptance and adjustment. This is a loss they're never going to get back. So it's not like someone who maybe had a heart attack and who has to just have a healthier lifestyle and needs to make some better choices. They get to go back to work. They get to go back to their family. They get to go back and now run that 5K they wanted to run. This person has lost, and especially the higher the degree of injury, the more adjustments they have to make. They have to learn a whole new way of living. So I said we were going to talk about spinal shock. This is complications. These are some of the complications. About 50% of patients develop spinal shock. So this happens right after the spinal cord injury. And this is when the area around the cord is damaged, it's bruised, swollen, so it's causing compression. So it makes you think you have more loss than you really do. Because if messages can't get through because of the bruising and the swelling, then they think there's more loss. Once the spinal shock kind of resolves, that bruising and that swelling and everything kind of calms down, then more messages can pass through, and that's why we don't really see full results or full loss of function until about 72 hours after. Although, technically, this can last days to months. So basically, there's just some kind of disruption in the communication between the upper and lower neurons. It doesn't mean that there's that permanent loss. It's just during this spinal shock. So their clinical manifestations that happen below the level of injury, they have low reflexes, loss of sensation, and that flaccid paralysis. That doesn't mean that those won't come back once the spinal shock resolves. We talk about shocks more, again, in test 3. So this is just a little preview. Neurogenic is due to the loss of that vasomotor tone. Blech. And it's usually with cervical or higher thoracic injuries. So typically above T6. Again, you have that loss of the sympathetic nervous system, so everything's dilating, blood is pooling, decreased cardiac output. And this will make more sense once we get to shocks. Bless you. And you get the symptoms that we talked about before, the hypotension, the bradycardia. The difference is that in most shocks you get cool, but with neurogenic shock, you get warm, dry skin below the level of injury. So that's the biggest difference with neurogenic shock. You get the hypotension, you get the bradycardia, right? Again, this is what we talked about before with the cardiovascular system. You have the dilation, you have a kind of venous pooling. It looks like you're losing fluid. You haven't technically lost any fluid, but because you went from fluid in this diameter to fluid in this diameter, it appears as though you've lost fluid. So it sends your body into shock. And so with shock, you typically have a low heart rate, a low blood pressure, but normally you're cool. With this, you have warm, dry skin below the level of injury. All right, this is a big complication, the autonomic dysreflexia. It is a massive, uncompensated, that CV reaction, mediated by the sympathetic nervous system. So normally, your sympathetic nervous system is going to react. So you have something that's stimulating. You are touching the patient. The bladder gets over-distended. Something causes stimulation, and the sympathetic nervous system kind of responds to that stimuli by constricting. Which one, Glenn?
Non-mediated.
Massive, uncompensated CV, cardiovascular reaction, mediated by the sympathetic nervous system. The parasympathetic nervous system is unable to counter these responses. So your body, you get stimulated somehow. Like I said, your bladder gets distended, right? Because they're having neurogenic bladder. Or they have a dilated rectum because they are having issues with constipation because they have hypomobility. You touch their leg. Something stimulates them, and the sympathetic nervous system, how does it respond? What does it normally do? It normally constricts, right? And the parasympathetic nervous system would counter that. But because those transmissions aren't happening, you have no parasympathetic nervous system to balance out this constriction. So the patient gets stimulated, they have this hyperconstriction, the parasympathetic can't react to it, and they get this life-threatening disease. I kind of talked about why. So this is after spinal shock has happened. They have to be able to respond. Their reflexes have to be there. Don't worry about it too much, guys. Basically, I said it. Distended bladder or rectum. They stimulate the skin, pain. That's what's causing it. They get some kind of stimuli. Something. Sympathetic nervous system goes into action. It starts vasoconstricting everything. Parasympathetic nervous system can't respond. So what do you think happens if you are vasoconstricting everything? Super tight. What happens to the blood pressure? It goes up, and it goes up high. Their systolic is like 300. They're going to stroke out. And that parasympathetic nervous system can't do anything because it can't get through.
It's like an often, like this happens a lot.
And it can happen anytime. It's after spinal shock has resolved, it can happen anytime. So anytime the patient gets overstimulated, that's why it's so important that we talk about the distended bladder and the distended rectum and controlling their temperature and controlling pain. Because if they get overstimulated and the SNS kicks into control and there's nothing there to counter it, they can develop this. Any point. Any point after spinal shock has resolved. So their blood pressure goes up real high. Their heart rate goes down real low, like 30 beats. They get a throbbing headache. Can you imagine how much pressure that's got to be in your head? With a systolic of 300, your poor little vessels are like. They have diaphoresis above the level of the injury. So think of everything wherever the injury is, everything above it is super high. Flushing of the skin above, blurred vision, nasal congestion. Everything's super engorged. And as long as the stimulus keeps happening, the SNS is going to keep going, right? So if you have a distended bladder, as long as that bladder is distended and stimulating, your sympathetic nervous system is going to keep going. So that blood pressure is going to keep going up. That heart rate's going to keep dropping. That headache is still going to, it's going to get worse and worse and worse until you take that stimulus away. They can get nausea, anxiety. Obviously, they're probably pretty anxious. So how do you think we treat it?
Take away the stimulus.
Take away the stimulus. Head of the bed goes up, first of all, right? If everything above the level of the injury is getting super engorged, do we want them laying flat? We want gravity on our side, right? So you're going to get that head of the bed up at least 45. You're going to cath them because most of the time it's caused by distended bladder. You can do a digital rectal exam, but be careful with that because, again, doing the exam itself is stimulating. So you want to make sure that you put an anesthetic on the area before you go ahead and disimpact someone. Remove all skin stimuli. So if their clothes are too tight, their shoes are too tight. And these are things to teach the family, right? Because you have to say, are we going to say, your patient's going to have autonomic dysreflexia. If their blood pressure is too high, please let us know. No. They're not going to be taking blood pressures at home. The first sign, what do you think the first sign and symptom they're going to see? Headache, right? Or some eye changes. They're going to say, oh, I have a headache today. Oh, God, I got to teach my family that if my patient with a spinal cord injury starts complaining of a headache, I'm going to teach them how to check a blood pressure. I'm going to tell them to go ahead and cath. I'm going to tell them to untie their shoes and take them off. Because do you think a person with a spinal cord injury knows how tight their shoes are? No, they can't tell you that. You're going to monitor their blood pressure. And like we said, the patient and family teaching. The alpha-adrenergic blockers. It's just meds that we use. It's just something, how do we monitor blood pressure? It's okay. So we're gonna ask you things. So when you're studying and when you're looking at these things, it's great that you can go back and forth with each other and say, what are signs and symptoms of autonomic dysreflexia? No, you're going to say, okay, you had a patient that presents with a headache and they're sweating. What is the nurse's priority intervention? Right? That's how we're going to ask it. So that's how you have to start studying when you're doing this, is give each other scenarios with this information. How do we know that treatment has been effective? The blood pressure is back to normal. Are we going to say blood pressure is back to normal, or are we going to give you a normal blood pressure? We're going to give you a normal blood pressure. So this is where this knowledge, or this is where level 4 shifts, and this is why level 4 gets such a bad rap, but we are so awesome. Yeah. But this is why we get a bad rap, because it's no longer, and correct me if I'm wrong, it's no longer just this, you know the information and you can spit it out on a question. We're not going to give you that because your patients aren't going to give you that. We want to know that when you walk into a room that you're going to recognize, oh crap, my patient with a spinal cord injury is showing a life-threatening clinical manifestation. What the freak am I going to do to make them not die? Okay? That's what we want to know. All right. So diagnostic studies, they're listed here. Gold standard's the CAT scan. Collaborative care. Obviously, we want to patent air. Yes, ma'am.
What were you earlier about the cardiovascular symptoms and respiratory symptoms? Are those all during the shock stage, or is that like afterwards when it, or is it like a return to normal? So then we look like, okay, so your blood pressure went up, so the return to normal is like.
They're always at risk for those symptoms. So like when we talked about respiratory, they may have some respiratory insufficiency initially and then develop a way to control that. But if they lose that way to control it, they could easily develop it back.
So I'm gonna need to know going into when we get report, like this is their baseline.
Mm-hmm.
It's not like they're used to being up in the 150s.
Are you talking about autonomic dysreflexia? Yeah, they should not. No, they should be back to normal. Once the stimulus is removed, then the blood pressure goes back to normal. Yeah, no, they don't sit in like the 200s or anything like that. They should go back to a normal blood pressure. Yeah.
Will their normal be lower because of the hypovolemia?
If we don't treat it. Yeah. So if they're not treated. So yeah, so they can go from one end to the next pretty darn quick because they're at risk for the hypovolemia. So we have to be careful with that and make sure that they're staying well hydrated. So if you have a patient who's got anorexia or who doesn't want to eat because that's the way they control it, they're going to be at way more risk of developing that hypovolemia. But if we overstimulate, then they're going to shoot their blood pressure back up. So it's a little confusing because they're at any point at risk for these signs and symptoms. They should have normal, except for obviously the higher injury. If they need mechanically ventilating, then we're going to control that all the time. But essentially, we're going to try to maintain as much normal as possible. So we want a patent airway. Always think ABCs, right? Whenever we take care of our patients, no matter what, if we haven't taken care of A in the question, airway, then you better be looking for airway in the answer. If we've taken care of airway and breathing, then we're looking for circulation. Ventilation, O2. We need an adequate circulating volume. So we need a mean arterial pressure of greater than 90 and control any bleeding. All right, because they're at risk for that hypovolemia. So we want to make sure they have lots of blood in there. Good volume. What's our main job? Prevent any other injuries. Good job, Morgan. Yeah. That is our goal. We don't want to prevent any more injuries, any more bad stuff from happening. That's why we have to be aware of what could happen so that we don't make it any worse. So stabilize the C-spine. Get IV access. Why? Because what do we want to give them? Fluids. Imaging. We want to see where the injury is, what type of injury we have. So those are immediately. They come in through the ER. We're seeing them for the first time. This is what we want to make sure they have. Ongoing, it's going to be their urine output, cardiac, O2, LOC, level of consciousness. Keep them warm. Monitor for any urinary retention, hypertension. Assessment and history. All right. I'm going to put this on. I'm going to pause this. Do you need a little break real quick? Okay. We don't have much more left, but take a real quick break.